Well, now I'll be discussing medicine question of grand test 186. Now, question 144. Which drug is used for myasthenia testing, gravis testing? Well, point to be noted, he's asking for testing, not for the treatment. If the question was for treatment, then the best answer was C, physiostigmine. But he's asking for testing. The answer is edroformium. Well, why this drug we use? Because it's a short-acting anti-cholinesterase drug. And that increases the concentration of acetylcholine at the neuromuscular junction. Increased concentration of acetylcholine in neuromuscular junction. Okay. Well, before I proceed further, let me discuss more about how we diagnose a case of myasthenia gravis. We all know very well that it is an autoimmune disorder. In fact, the special thing about myasthenia gravis, it is a T-cell autoimmune disorder. Rather, because most of the autoimmune diseases are due to B cells. Now, if we have to diagnose a case of myasthenia gravis, what is the best initial test? Okay, answer is acetylcholine receptor antibodies. This is the best initial test. Okay, suppose this is negative, then we go for anti-MuSK antibody. These two have very high yield in testing about the myasthenia gravis. But if you have to confirm it, most confirmatory tests is single fiber EMG. Edroformium is a test, but neither it is an initial test nor it is confirmatory test. It just is test for myasthenia gravis. Question 145. Nucleotide repeat sequence is seen in all except. The answer is Wiskott-Eldridge syndrome. Now, just to inform you, this sequence is also seen in condition like Fragile X syndrome. Okay, it's also seen in myotonia dystrophica. Is also seen in Friedreich's ataxia. Right? Now, what is the importance of this in case of Huntington disease in particular? And in Huntington disease, we have a cause anticipation. As you know very well that in case of Huntington disease, it is autosomal dominant in inheritance. In that way, the disease can come from mother or father. If the disease comes from mother, it has a late manifestation. Or if the disease comes from the father, it has an early manifestation. And one more thing, when we are talking about anticipation, in every subsequent generation, the disease tends to appear in the earlier age group. There's again one more thing about the anticipation. Now, asbestosis causes all except. The answer is atelectasis. As far as asbestosis is concerned, we know very well it's a occupational lung disease. Well, pleural plaque is the most common manifestation. And the pleural plaque are mainly seen in the diaphragm, diaphragmatic surface of the pleura. One more thing, most common cancer caused by asbestosis is bronchial carcinoma. But this is the one cancer which is specifically caused by asbestosis. But point to note it is mesothelioma is the not the most common cancer. It is always bronchogenic carcinoma. Pleural fusion can occur in these patients, again a manifestation of asbestosis. Okay. Well, and of course the commonest cause of death in these patients is, one of the common cause of death is mesothelioma. Of course, bronchogenic carcinoma can also lead to death. Vitamin E deficiency present with all except it does not present with perifollicular rash. Well, it can lead to peripheral neuropathy. Now, what are the other features that we see in case of vitamin E deficiency? It leads to posterior column dysfunction. Posterior column dysfunction. And we also know very well that posterior column carries position vibration sense. And that's why they have a rhomboectasis positive. I hope you know about rhomboectasis. We ask the patient to stand and he keeps his feet like this close and he stand and we ask the patient to close the eye. If the posterior column, if his lesion is there, he will sway like this. This is so-called positive rhomboectasis. And of course, rhomboectasis classically we use in the testing for pernicious anemia. Pernicious anemia occurs due to vitamin B12 deficiency. In that case, there is not only there is anemia, there is also involvement of posterior column. Well, because of posterior column is involved, so they have ataxic gait also, and I discuss about peripheral neuropathy. What else occur in this patient? They also have spinocerebellar dysfunction. Vitamin E deficiency can also lead to hemolytic anemia. It can also lead to hemolytic anemia. Okay, and classically it leads to pigmented retinopathy. Pigmented retinopathy. Okay, it leads to myopathy. Now I have a question for you. This is a rank number 1 question. I discussed that in this case we get hemolytic anemia. Hemolytic anemia we also get in the case of chronic alcoholism. Or what I can say, this is seen in alcoholic liver disease. Now what is the name of that hemolytic anemia that we see in the case of alcoholic liver disease? Stop the video, write down the answer. Well, I'm sure by now you have written the answer. The answer is Zeev syndrome. Zeev syndrome. It's in this chronic alcoholic patient, because of high amount of lipid, they develop acanthocyte. Acanthocyte. They have, that means RBCs, normally they have a surface like this, but in this case we have surface like this, acanthocyte, so-called acanthocytosis. And that's why RBCs are prone to hemolysis in the case of chronic alcoholic liver disease. This is a rank number 1 question. let's discuss question 148. Well, we have patient X-ray is showing it just like a X-ray. Classically, is a case of emphysematous. Emphysema type of picture is there in X-ray. Okay, and PO2 is less. That means it is much less normal. I hope normal PaO2 is 94 to 104, and here it is 65. It's markedly reduces there. And FeV1 FEC ratio less than 65%. That means it's a case of obstructive airway disease, and that is confirmed by the X-ray. What we mimicking like more of a hypoxia is there. And one more thing, something very interesting to know. Why not chronic bronchitis? First of all, in chronic bronchitis, we don't get X-ray picture like this. Number two, in this case, CO2 is quite normal. So hypoxia is there, CO2 is near normal, it's absolutely normal. So it's more of a type 1 type of picture is there. Okay, not a classical picture, but definitely there's no hypocarbia. So it goes more in favor of emphysema. In emphysema, there's no special use of steroid except it can reduce acute exacerbation. Homoxin can help. But antibiotic has not much role in emphysema. But this is the most, can be beneficial, but this is the most beneficial. So in the exam, patient examiner never say choose the right answer, he say choose the most appropriate answer. The most smoking cessation program is the best. It's the only thing which can really reduce. It can reduce the further progression of the disease. It will help in acute problem or long-term problem, but it will not reduce the progression of disease. If the patient keep on smoking and using homoxin, it's not going to benefit much. Hence, the best answer to this is stopping of smoking cessation best. One more thing, if somebody asks you in lung cancer also, the best treatment is always stop the smoking is one of the best treatment modalities there. Okay. Now, as we are getting a case of emphysema, so let me tell you, what are the clinical signs that you should know about emphysema? The clinical sign is barrel-shaped chest. Number two, area of cardiac dullness. Is reduced, and liver dullness is shifted downward. Let me explain to you. When I say these are classical signs, the three classical features of signs of a case of emphysema. When I say barrel-shaped chest, AP diameter is same as transverse diameter. Normally, transverse diameter is more than the AP. Here it becomes equal. Area of cardiac dullness, that means when we are doing percussion, we find because of a large amount of air in front of the heart, the area of cardiac dullness reduces. And normally liver dullness is usually there in 5th intercostal space on the right side. Here, dullness may be there in around 7th or 8th intercostal space. That means liver have been pushed downward. Well, we get one more beautiful ECG. He complained with palpitation, and we are getting P waves, 1 QRS. So we are definitely getting 4 P wave followed by one ventricular rhythm. This is a case of atrial flutter with 4:1 AV block, right? Now, well, let's say how much is the ventricle rate in this case. How we calculate ventricle rate? 1500 divided by number of small square between two R wave. 1, 2, 3, 4. That is 20. So ventricle rate here is 75. But atrial rate is almost 300. Why? It's 4:1. We can say in roughly that it is around 300, right? That's why the patient complaint of palpitations there. Now, how to treat this case? We can give one of the common drug we use is Digoxin. What Digoxin does? This converts flutter into fibrillation. You convert it into atrial fibrillation. That's the advantage of using Digoxin in this case. Okay. Now, when we are using Digoxin, now one question, this is a very important question. When we use Digoxin, as a side effect, it can lead to all arrhythmias, all blocks. Now, the commonly asked question, one of the very commonly arrhythmias in this is bigeminy. Bigeminy is a very commonly encountered arrhythmia in the case of digoxin toxicity. What is this? Normal arrhythmia, normal ectopic, normal ectopic. Normal ectopic, normal ectopic, normal ectopic. That means there is one normal beat followed by one ectopic. This is bigeminy. This is a very commonly arrhythmia that we see. Now, which arrhythmias or block are never seen in digoxin toxicity? Not seen are atrial flutter. And second is type 2B block. These are never seen in the case of digoxin toxicity. Now, which is the most characteristic arrhythmia that we see in digoxin toxicity? That is non-paroxysmal atrial tachycardia with variable block. This is the most characteristic arrhythmia that we see in digoxin toxicity. At time in the exam, they don't write full form. They just write PAT with block. Even if they write this, although this is not the right language, but you have to go for this answer. So this is about digoxin toxicity. Now in digoxin toxicity, we get yellow vision. Now rank number 1 question for you. Tell me in which condition you get blue vision. Which drug lead to blue vision? You can stop the video, write down the answer. This is the rank number 1 question. Well, I'm sure by now you have written the answer. Answer is sildenafil. Sildenafil can lead to blue vision. Rank number 1 question. Now the question number 150. Paraneoplastic syndrome seen with Hodgkin disease is cerebral degeneration, right? Well, we talk more about paraneoplastic syndrome that we see in Hodgkin disease. We see first of all, it is in Hodgkin disease, it's an acute cerebral degenerative disease occur. Now, and this cerebral degeneration can occur in Hodgkin disease. And Hodgkin disease, this is due to anti-TR antibody. Anti-TR antibody. Now this acute cerebral degeneration can also occur in breast carcinoma, gynecological cancer. Then it is seen due to anti-YO antibodies. They are all acute. And extra edge question, there can be subacute cerebral degeneration also. Subacute cerebral degeneration is seen in cancer like small cell lung cancer. It can occur in thymoma. It can occur in neuroblastoma. Okay, but here all are subacute. Now a rank number 1 question for you. Well, in Hodgkin disease, glomerular involvement can occur. Now tell me what is the classical type of glomerulonephritis that we see in Hodgkin disease. Rank number 1 question. Stop the video. The question is, what type of glomerulonephritis can occur in Hodgkin disease? Stop the video, write down the answer. Well, the answer of this question is it can lead to minimal change glomerulonephritis. Rank number 1 question is this. Okay. Question 151. T28 is associated with Burkitt lymphoma. Well, extra knowledge. Burkitt lymphoma is a highly malignant type of non-Hodgkin lymphoma. There is this translocation is there, but there also occur other translocation. Like first of all, we also get we get C mice gene. In non-Hodgkin Burkitt lymphoma, C mice gene are involved, and the peripheral smear you get starry sky appearance, and we also get T814 mutation in Burkitt lymphoma. Of course, this is also there. Okay. Question 152. Poor prognosis is indicated by is monozoan 7. Let us see what are other features which indicate poor prognosis in a case of AML. It is again indicated by poor prognosis also indicated by monosomy 7, monosomy 5, also by inverse 3. Now, what are the good prognostic feature? This is a good prognostic feature. This is again, transfer 15-17 is again a good prognostic feature. A normal cytogenicity is again a good prognostic feature. Even translocation 821 is also a good prognostic feature. Okay, so in a case of acute myeloid leukemia, bad and good prognostic features are this. 153, basket shape. This is seen in Alport syndrome. Now, let's talk about what happened in acute post-streptococcal glomerulonephritis. For that, we got to learn the first basic concept. Well, I have a simple question for you. Can you draw the histology of normal glomerulus? Try. Okay, just write down, draw the diagram. What is the normal histology? Remember, I'm talking about histology of normal glomerulus. Well, the answer is like this. This is the epithelial cell. This is the foot process. This is the basement membrane. This is the capillary endothelium, capillary lumen with the blood flows, and this is the mesangial cell, mesangial matrix. Okay. Now histology. Now in post-streptococcal, antigen antibody is deposited in the subepithelial area. This is subepithelial area. Why subepithelial? Because this lies between the epithelium and the basement membrane. Now, this antigen antibody complex also get deposited in the membrane, that is basement membrane. So intramembranous, I intra, M for membranous. They are also deposited between the membrane and the endothelium. This is known as subendothelium. Subendothelium. Got it? But so we are getting antigen antibody at 3 places, but these antibody remain for 2 to 6 weeks. After that, they disappear and become normal histology. Recurrence is not a feature. Recurrence is not a feature in case of post-streptococcal. That's why we do not use no prophylactic drug. No prophylactic drug in case of post-streptococcal glomerulonephritis. NADAS criteria is simple. It's an assessment for a child for presence of heart disease, where we mainly talk about the grading of the murmur. It's a pediatric question, nothing need to discuss. Okay. Now, etiology of Dressler syndrome. So first of all, let's talk about what the Dressler syndrome. It is a late complication of acute MI. It occurs about 2 to 3 months post-MI. And in this case, classically patient come with pain chest. And there are 3 P's. That is pyrexia, fever, pleurisy, pericarditis. Due to these 2 reasons, patient has pain chest. And how we diagnose by auscultation, you may get pleural rub and you may get pericardial rub. Now the question is, how to differentiate between the 2? Well, you ask the patient to stop the breathing. This rub will continue. Now you ask the patient to take a deep breathing in and out, you find this is there, pleural rub is there. And one more thing, when you ask the patient to bend forward, and this intensity of this rub gets slowed down. Okay. Now, etiology of Dressler syndrome is autoimmune. So we can give NSAID in the treatment, or we can also use steroids. Okay. This is about Dressler syndrome. All are true about hyperthyroid except anxiety, weight gain. In this case, in hyperthyroid, weight loss occur. Why weight loss occur? Because in this case, there is increased epinephrine-like activity. Epinephrine-like activity. I hope you are well aware that thyroid hormone, thyroid hormone, they act indirectly by increasing the action of epinephrine. That's why we get all the clinical features due to high amount of epinephrine, like tachycardia, palpitation, anxiety, sweating. And there is increased catabolic state, and that's why weight loss occur. Weight gain occur in hypothyroid. Okay. Well, one very special question for you. Stop the video, write down the answer, rank number 1 question. In all the cancers, weight loss occur. But there is one special cancer where weight gain occur. What is the name of that cancer? Stop the video, write down the answer. Well, the answer of the cancer where weight gain occur is insulinoma. Rank number 1 question. And what is the best method to diagnose insulinoma? 72 hours fasting test. Is hemoptysis and grade 3 glubbing? Probable diagnosis is, well, most likely is non-small cell lung cancer. In TB, hemoptysis occur, but clubbing is usually not a feature. Similarly, in sarcoidosis, you may get clubbing, but hemoptysis is not a very important feature. Small cell lung cancer does not have clubbing. The non-small cell lung carcinoma is the best answer. Okay, well, now we talk about, in which cardiac condition you get hemoptysis? The answer is mitral stenosis. Now one more question. We get many endocrine feature in lung cancer, especially small cell lung cancer. Small cell lung cancer, we get feature of increased SIADH. We get Cushing syndrome. There's increased ANP also. This is due to increase ADH. This is due to increase ACTH, and ANP lead to natriuresis. Now come the rancor question. Tell me, in which condition, in which lung cancer you get hypercalcemia? Stop the video, write down the answer. Well, hypercalcemia occurs in squamous cell lung cancer. Rather, in small cell lung cancer, hypocalcemia occurs. This is due to calcitonin. So all neuroendocrine features are seen in small cell lung cancer except one, hypercalcemia, that is seen in squamous cell lung cancer. Fluent aphasia and preserved compression is seen in conduction type of aphasia. For that, let's learn the basic concept about speech. Basic concepts about the speech. So first we will learn anatomy and physiology of speech, then we talk about. Here is the brain, central sulcus, motor cortex, this is the head area, this is the leg area, head area. This is motor cortex. This is the occipital lobe, temporal lobe, parietal lobe. In the posterior part of temporal lobe, we have a auditory area. And here we have a Wernicke area. Wernicke area is a sensory speech area. And this lies in the superior temporal gyrus. In the inferior temporal gyrus, we have a Broca's speech area, like in the inferior frontal gyrus. Okay, this is a motor speech area. Inferior frontal gyrus. Now these two are united via arcuate fasciculus. This is normal anatomy. Let's discuss physiology. Suppose we ask somebody, what is your name? Our words go to his both auditory center, which are lying in both the temporal lobe. Here there's some sound has gone. And then this sound come to Wernicke area, which lies in there's only single Wernicke area in the dominant superior temporal gyrus. Here speech is understood. Whatever question, what is your name? It is understood. Now this message will come to Broca's area. Broca's is a motor speech area. And this Broca's area lies quite near to head area in the motor cortex. So now Broca's area will give a command to head area, and the vocal cord will say, my name is XYZ. This is the basic physiology of speech. Now we come to pathology and medicine. Suppose there is one patient whose Wernicke area is not working. You ask, what is your name? Your words go to his ear, and they go to his auditory area, go to Wernicke area. In Wernicke area, he understands what is your name. Now it gave a command to Broca's area, and the Broca's area will say to the head area, and the name my name is XYZ. Okay, this is normal speech. But suppose this is not working. You ask what is your name. Your word go to his auditory area, but matter go to Wernicke, but he cannot understand. But he heard something, but he did not understand. So you ask, what is your name? No, I will not go to movie. Arey, what is your name? No, I have taken my lunch. You are talking something, he is talking irrelevant. So in Wernicke defect, there is irrelevant speech. Suppose this is all right. This is damage due to any reason. You ask what is your name. Your words go here, your words come here. He understood what is your name. Now message come to Broca's area, but it cannot give a command to vocal cord lips. So what you say, you ask what is your name. He understood. Message come to Broca's area, but he cannot give a command to vocal cord lips. You say what is your name, he will just keep on watching you. What is your name? No reply. Will you go to movie? Will you have dinner? Then why don't you speak? He's not able to speak out. Why? Defect is in Broca's area. So in Broca's area, speech outflow is gone. Speech outflow is gone. Okay? Well, suppose this is damaged. Then what happened? Repetition is lost. Now come the rank number 1 question. Tell me what the mechanism by which we can say repetition is lost. This is the rank number 1 question. The answer is, in this case, this is gone. But remember, his Broca's area is normal and his Wernicke area is normal. There is no problem. His spontaneous speech is normal. His spontaneous speech is normal. What do you mean by spontaneous speech? He is hungry. He says, he can say, yes, I am hungry, because this is normal. He says, I am hungry. You listen. You say, what did you say? Repeat. Now your word goes to auditory area, they go to Wernicke area, but this cannot transmit to Broca's area. So that's why repetition is lost. Spontaneous speech is normal, but repetition is lost. This is the mechanism why. So conduction abnormality, this is a conduction. Conduction abnormality, repetition is lost. Well, this is the case of WPW syndrome. How do you know? First of all, PR interval is short. Normal PR interval is 0.12 to 0.20 second. Here the point is less than 0.12 second. In this case, it is only 0.08 second. There are only 2 small square. Plus, you get a notch in the ascending limb of R wave. This notch is seen in delta wave. It's known as delta wave. Okay, so that can lead to a type of pre-excitation syndrome. Pre-excitation syndrome, which can lead to a type of, it can lead to atrial arrhythmias. Because the re-entry phenomena. And in these cases, atrial fibrillation can occur. But something very interesting, in this case, digoxin is absolutely contraindicated. There are some conditions where digoxin is absolutely contraindicated. One is WP, and second is HOCM. In HOCM also, digoxin is absolutely contraindicated. Oliguric phase of ARF characterized by hypokalemia. There can be pain chest due to pericarditis. Metabolic acidosis occur due to metabolic acidosis. and in this case decreased bicarbonate is the classical feature. Hypertension is a feature of ARF, can occur, but it is usually hyperkalemia occurs. In ARF and CRF, hyperkalemia occurs because of decreased sodium ionic secretion, and that's why let's learn the basic concept. Why acidosis and why hyperkalemia? These are tubules, basic concept. Normally, aldosterone, A for aldosterone comes. It tends to absorb 2 sodium with water. Okay, 2 sodium with water. But here, there may be some problem in sodium reabsorption. So normally H ion goes out, potassium goes out, normal. But in these cases, there may be problem in sodium reabsorption. Sodium is not reabsorbed, H ion remain in the body, that lead to acidosis. Potassium remain in the body, that lead to hyperkalemia. So in this case, metabolic acidosis occur and hyperkalemia occur. Hypokalemia usually occurs in diuretic phase of acute renal failure. It usually doesn't occur in oliguric phase of acute renal failure. Pneumatocele is caused by, it's a beautiful controversial question. Best answer is always staph. If this is the answer, beyond doubt is the best answer. Otherwise, it can occur in all the 4. But however, I am marking this. Why? Again, this classic, beautiful, controversial question. Well, we know very well that the most common cause of community-acquired pneumonia, what we write as CAP. CAP is community-acquired pneumonia. The commonest cause is staph pneumonia. And I told you pneumatocele, which are nothing but small cysts in the lungs, which develop after pneumonia. They can occur in all, most commonly develop in this. Since this is the most commonly cause of community-acquired pneumonia, so we are most likely to see in this type of pneumonias. And we know very well that pneumatocele can rupture and they can lead to pneumothorax. Pneumothorax. Okay. SIADH occurs due to which cancer? Small cell lung cancer. Let's learn the basic concept. In SIADH, there is increased amount of ADH. And we know very well that ADH is basic concept. Basic concept. Normally ADH act on the collecting tubule and it absorbs only pure water. As excess of water enter in the body, that lead to hyponatremia. Now this SIADH can occur in many conditions. If you see the book, a large number of lists is there, but you should not forget following most important. The SIADH occur in head injury, or sometimes they write subarachnoid hemorrhage. It occurs in small cell lung cancer. It occurs in hypothyroid. It may occur in meningitis. It can occur in porphyria. It can occur in vincristine. These three are the most important reason, a very commonly asked question of SIADH. And now rank number 1 question. Write down what happened to renin and what happened to aldosterone level in this case. Rank 1 question. What happened to aldosterone level and what happened to renin? R renin, A for aldosterone level in SIADH. Write down the answer. Well, both are reduced. This is a rank number 1 question. Okay. Now, aldosterone renin, Addison disease, reduce, increase. Cone syndrome, increase, reduce. Secondary hyperaldosteronism, secondary hyperaldosteronism, increase, increase. And in SIADH, reduce, reduce. It's a very frequently asked question, is a rank number 1 question. Russell body are seen in plasma cells. Okay, well, multiple myeloma is a plasma cell disorder. In multiple myeloma, there is increased osteoclastic activity. And that's why lytic lesions are seen. But since osteoblastic activity is normal, so alkaline phosphate level is normal, and due to increased osteoclastic activity, hypercalcemia occurs. What are the other findings? In multiple myeloma, the mnemonic CRAB should never be forgot. C for hypercalcemia, R for renal failure, A for anemia, B for bony pains. The classical 4 signs in the case of multiple myeloma. It can lead to chronic renal failure, of course. Now, what is special thing about this CRF is one condition where a patient has CRF with normal or enlarged kidney size. But this we see in few more conditions. But what is the unique thing in these patients? In this case, we are getting hypercalcemia. Is the only condition where we get chronic renal failure with hypercalcemia. Rest in all chronic renal failure, we get hypocalcemia. This is the rank number 1 question. Okay, so this is all about grand test, 186 medicine question. Well, I have one more information for you. I have recorded all my lectures of medicine in Medicine e-Gurukul. Okay, this app is available. For that, you have to go visit our website. This is the ultimate app. Every topic I have started from basic concept and I have gone to depth of the subject, and I have integrated many other subjects also. That means whatever there, at least 13 to 14 subjects I have included. And if you read this much, you don't need to read any other book. In any NEET exam or AIMS exam, 30% question will come from my app. 30 question comes out to be around 80 to 90 question in NEET and about 70% question in AIMS exam also. Even a single question done right or wrong can change the result. And 30% question are there in one app. Each app is of 20 minutes. So what I always say is just read one lecture per day and get sure success in your exam from Medicine e-Gurukul by Dr. Mukesh Bhatia. Thank you very much for watching this video. Thank you.